This is a C. Jason podcast, and I am Dr. Morgan Grams from New York University. I am privileged to have the opportunity to present this work on behalf of my co-authors. The impetus for our study, discrepancies between Cystatin C-based and Creatinine-Based estimated glomerular filtration rates, stems from the increasing use of Cystatin C in clinical care, a practice driven in part by the recommendations from the NKF-ASN Task Force on Reassessing the Inclusion of Race in Diagnosing Kidney Diseases. As you all know, GFR can be estimated using serum creatinine alone, Cystatin C alone, or both creatinine and Cystatin C. Estimation of GFR based on serum creatinine alone is by far the most common practice, but eGFR based on both creatinine and Cystatin C is the most accurate estimate of measured GFR. Although not quite mathematically accurate, we can think of eGFR based on both creatinine and cystatin as almost an average of creatinine-based eGFR and cystatin-based eGFR. Therefore, checking Cystatin C is going to be most helpful when cystatin-based eGFR is very different than creatinine-based eGFR. With that in mind, our paper had three aims. 1, to help discern who will have big differences in creatinine-based eGFR and Cystatin C-based eGFR. 2, to see if those big differences persist over time. And 3, to see what those differences mean in terms of common CKD-associated lab abnormalities and adverse outcomes. The study population was derived from ERIC, or the Atherosclerosis Risk in Communities cohort, which enrolled people ages 45 to 64 years from 1987 to 1989. We evaluated for big discrepancies in cystatin-based eGFR compared with creatinine-based eGFR, defined as a 30% difference in either direction, at visit 2, when participants were on average 57 years old, until visit 6, when participants were on average 80 years old. The first thing we noted was that the prevalence of big discrepancies increased over time. At visit 2, when participants were middle-aged, the prevalence of having cystatin-based eGFR much lower than creatinine-based eGFR was 7%. At visit 6, when participants were approximately 70 to 90 years old, the prevalence of having cystatin-based eGFR much lower than creatinine-based eGFR was 23%. In contrast, the proportion with cystatin-based eGFR much larger than creatinine-based eGFR was small and fairly consistent over time, from 3% at visit 2 to 1% at visit 6. People that had big discrepancies generally continued to have big discrepancies at the subsequent visit, although of course there was some movement. Risk factors for having cystatin-based eGFR that was much lower than creatinine-based eGFR, and here I'm going to focus only on that one direction since it was so much more common, included older age, female sex, higher body mass index, recent weight loss, current smoking, a higher creatinine-based eGFR, higher C-reactive protein, and a variety of comorbidities, history of stroke, coronary heart disease, heart failure, peripheral artery disease, atrial fibrillation, diabetes, and hypertension. When someone had a cystatin-based eGFR that was 30% lower than creatinine-based eGFR, they were more likely to have lower hemoglobin, higher phosphate, higher PTH, higher uric acid, and higher FGF23, all in the expected direction if creatinine-based eGFR were overestimating true GFR. Finally, discrepancies with cystatin-based eGFR 30% lower than creatinine-based eGFR were associated with subsequent adverse outcomes, approximately 50% higher risk of kidney failure, heart failure, acute kidney injury, and death. So, in conclusion, discrepancies in creatinine-based eGFR and cystatin-based eGFR are common. Older individuals and ones with more comorbid conditions are more likely to have cystatin-based eGFR that is much lower than creatinine-based eGFR. In people with cystatin-based eGFR much lower than creatinine-based eGFR, our results suggest that creatinine-based eGFR alone overestimates kidney function. Thus, our study suggests that increased measurement of Cystatin C, particularly in an older, sicker population, is useful. Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.